Welcome to all of you out there. My name is Tina Vilsbøll. I'm a professor at Steno Diabetes Center in Copenhagen, and I'm really thrilled to engage you in this program entitled Empowering Type 2 Diabetes Management, the Evolution of Basal Insulin Therapy. Today, at this first part, I'm joined by two interesting colleagues here to focus on understanding clinical inertia in type 2 diabetes and multidisciplinary approach. Welcome to Jen Safari, who's a primary care physician from Toronto, Canada. Welcome, Jen.
Hi, it's a pleasure to be here, and I'm very excited about joining you in the program.
Good to have you on board. And welcome to Ostap Soroka, who is a patient advocate, also from Toronto, Canada. Welcome, Ostap. An honor to have you on board.
Thank you. Thank you very much. I'm very happy and honored to be invited and looking forward to a good discussion. And I hope this helps a lot of people.
Yeah, thank you. So let's get started. Our focus is today to discuss some of the current barriers in effective insulin therapy, focusing on individuals with type 2 diabetes. What are the limitations and why are we a little bit behind when we sit every day in front of patients with diabetes? Very short, I think many of you already know that insulin is still a backbone for the treatment of type 2 diabetes. We have recent years focused a lot on modern glucose-lowering drugs with GLP-1 receptor agonists and SGLT2 inhibitors. And really, I think we all agree that they're interesting tools, they save lives, and they have been game-changing in the treatment of type 2 diabetes. However, every day I'm in the clinic and I see patients with type 2 diabetes, I use insulin. We've had insulin on the market for more than 100 years, and the insulin analogs that we are using are more and more sophisticated, you could say, or really elegantly developed, so they are more alike the human insulin. They are not initiating autoantibodies, and we have basal insulin and we have bolus insulin, but when we're talking about type 2 diabetes, it's very much focusing on basal insulin. And also, if patients are very catabolic or severely it's absolutely okay to start with insulin and then afterwards discuss whether we should add modern glucose-lowering drugs on the top thereafter. In short, the recommendations say that we should always start with basal insulin, and then if it's not enough on the top, as we'll also come back to later, on modern glucose-lowering drugs. If it's not enough, then later down, basal bolus insulin are initiated in some patients, but I must already declare here that I'm not a big fan of basal bolus insulin to individuals with diabetes. And what's your interpretation in respect to the delay of insulin in everyday clinic? Please, Jen, share some of your thoughts here.
Yeah, absolutely. So, as you said, at the time of diagnosis, actually, insulin is recommended as an initial therapy if a person is decompensating. So, they're losing weight, they have ketones, they're just not doing well. There's actually recommendation to start insulin right off the bat. Thankfully, the majority of time, that's not where we use insulin. And as you've alluded to, we have great drugs like the GLP-1 receptor agonists, SGLT2 inhibitors that have other, benefits beyond just lowering the sugar with the cardiorenal benefits. So often patients are actually started on these agents. They're on metformin already. And those who are not achieving their targets, that's when we start talking about starting insulin. And the first insulin we go to is the basal insulin. So if you think of that timeline, if a person is diagnosed with diabetes, they're started on one agent, 3 months later, they're not at target. Theoretically, we add a second agent, 3 months later, they're not at target, you're intensifying treatment. A person who's not achieving target, you can think that they would probably be a good candidate to start insulin by about a year or so. But that's not what's happening. And there's lots of literature to show that patients who actually need insulin are delayed in their initiation for the reasons we're going to get into shortly. But to just give you a sense, there was a large trial that was done in Canada to look at the average time between a patient needing insulin and being initiated on insulin. And that timeline was 9 years. And it's not 9 years of good control. Unfortunately, it's looking at A1C levels that are beyond 9%, which is really not ideal because we know when diabetes is not well controlled, there's a lot of complications that are developing due to that. We know it is sort of the backbone of treatment, and globally, about 40% of people will actually need insulin. And we're not getting there for a number of reasons. I mean, patient barriers, physicians barriers. Uh, we've got to break down those barriers.
Yeah, really. And I fully agree with everything you said. We want patients to be well controlled. We want them to go to target in order to avoid microvascular, but also macrovascular complications, because we want our patients to be healthy. We know if they're dysregulated, they get infections. We want them to, keep on having normal vision and so on. What are your thoughts when we talk about insulin, Ostap? Can you share with us some of your personal experience and also seen from another perspective, please?
Well, I began before I was diagnosed with all the typical misconceptions that you have out there with people that once you become an insulin injector, your life is essentially over. Complications get worse. Your life expectancy goes down. Everything gets worse. And then the same sort of misconceptions about being diagnosed with diabetes and why it happened and how it happened. And so from uh, from the moment that I was diagnosed, I was not only diagnosed and had interventions, but my doctor, who's great, also had gave me a lot of education on the realities of it, which knowing these things not only calmed me down, but it also empowered me to stick with the program, not worry about things that aren't real, encouraged me to learn more, and that in turn encouraged me to be what I suppose some doctors call a good patient, in that I took the things I was supposed to take seriously. And that brings into light, I've had three, I would say, so to speak, three encounters with this topic. The earliest was when I was a teenager, 3.5 decades ago, with an uncle who had a lot of problems and eventually was diagnosed. He didn't take the pills he was given. He would never check his blood. He would eat and drink the wrong things. Things got worse. Eventually, it took, I don't know if it was 9 years, but it felt like it took a long time because it was a topic of conversation in the extended family for a very long time. And things just kept getting worse. And eventually, he was, I think, put on insulin, but took it infrequently, and it was the sort of the typical nightmare scenario of his doctors at the time not pushing him well, not educating him, and he being a somebody who just didn't take things as he should. So that really colors how you think about things. My second experience sometime later was with my mother when she was diagnosed. Sort of slow rollout. Not super slow, but it was a slow rollout, but complicated by the fact that my my mother is what you might call a difficult patient. I don't know what her doctor thinks, but certainly at home there was a lot of pushback, and I don't want to be on more drugs, and I'm not going to inject things, and this is ridiculous, and I can take control. And also complicated by me, because at this point I was still laboring under all sorts of misconceptions. So I made her life unnecessarily difficult by really fearing for her and therefore getting on her case in ways that I later learned when it was my turn to be diagnosed that aren't necessarily entirely true the way most people think. And I wish everyone and everyone's doctor knew that there's no need for delay. the dangers that people think about injecting insulin. Once, if you're on a good regimen, you do what you're told. It works well.
Yeah, what a story, Ostap. Really, really beautifully with your personal experience. And I think you're not the only one out there. A lot of people have a lot of history from their families. They're worried about it. They delay everything. And you started on insulin from the beginning. And I think that's what we're facing. One thing is the guidelines. One thing is the doctors worries about complication, and then the adaptation by the patients. Really, thank you so much for sharing it. And I think we'll hopefully all you out there will join us in the next session, where we will talk more about potential tools to get beyond these barriers and how to do it in everyday clinical life with maybe once weekly insulin. Thank you, Jen. Thank you, Ostap, for joining us in this part of the session, and looking forward to seeing you in the next ones.
Thank you. My pleasure.
Welcome to everyone out there. My name is Tina Vilsbøll. I'm a professor at the Seno Diabetes Center in Copenhagen, in Denmark, and I'm really thrilled to be part of this program today, which is part 2. And we are focusing again on insulin, but now we are focusing a little bit more on the evolving options with respect to insulin therapy. It's not only me, it's also Jen Zarifa on board. Jen is from Toronto in Canada. Welcome. She's a primary care physician. Welcome, Jen, to be on board.
Thank you for inviting me. I'm very thrilled to be here to talk about insulin, which is a topic that's very dear to my heart.
It's wonderful to have you here because, yes, insulin is important for us as clinicians. We use it every day when we're treating patients with diabetes, maybe a little bit less today than 20 years ago because we have these modern tools on board. We do not use them as probably early as we did before, but it is still a backbone in the treatment of diabetes. But where are we today, and where will we be in the very soon to come future? But before I hand over to Jen to talk about icodec, I'll just, set the scene by recapping what are the strengths actually in respect to discussing once weekly insulin. Because in short, the strength, I think we've all been sitting in front of patients where we have tried for a long time, months, maybe even years, to convince the patients that they should go on insulin. We know from many studies that patient adherence is complicated when you go on insulin. Let me hand over to you, Jen, and can you just briefly summarize what's the status right now with respect to the first on the market once weekly insulin, which is insulin icodec?
Yeah, absolutely. And I'm just going to echo what you said about the burden of injection, because it is really a huge burden for patients. And 90% of actually patients in surveys and trials have identified that this daily injection is a burden. And 3/4 of patients actually discontinue their insulin because of the daily injection. So it is actually great to be practicing at a time where we have access to an insulin that can be a game changer with it being injected once a week. But like you said, it's important to make sure that it's effective, and even more important to make sure that it is safe. So the Onwards trial are the trials where insulin icodec was compared against the insulins that we use every day. So insulin glargine, insulin degludec, and sort of the third trial in patients who were naive to insulin was insulin icodec compared to any insulin, basal insulin, I should say. And through the trials, we actually found that icodec was not just as efficacious in lowering patients' A1C to target, but it was statistically superior. Whether that becomes clinically superior, that's to be debatable, but at least it was a very effective insulin in reducing sugar. And when you look at the safety, and the one safety thing that we always want to look at is hypoglycemia. Both, us are worried about hypoglycemia, but certainly patients are always worried about hypoglycemia. And as you said, this is a once weekly. So what happens when I inject it? And the data has actually shown us that the events of hypoglycemia are similar between the once weekly insulin compared to the daily insulin. And overall, these hypoglycemic episodes were very low. So it's very reassuring that we can now offer this to our patients to decrease that burden and potentially break that inertia in starting someone on insulin.
Yeah, that's really exciting. And as I already said very briefly, it is not the only insulin given once weekly that is approaching the market. Efsitora is still not, it's not done with the full phase 3 program, but what we have seen so far is really, really interesting from the phase 2 trial. We will, during this year, see the full phase 3 program. And what I've seen so far is exactly as you very, very beautifully elucidated, Jen, with icodec, is that it's efficacious, it's safe. The number of patients with hypoglycemia is not worrying at all. So I think it's really, really positive and interesting. What do you think about combining GLP-1 and insulin in everyday clinical life? Maybe talk about the fixed combination. Have you used it, and do you see that as a future treatment?
Yeah, I mean, I have used one of the combinations, and mechanistically, it makes a lot of sense, right? There's synergistic mechanisms of action with the GLP-1 counteracting some of the potential weight gain that you get with insulin. And so it makes more sense, and the data supports that. It's one injection, one pen, less poking, less titration. So there's a lot of positives of having a combination GLP-1 receptor agonist and insulin. I have to say, however, that it's not one that I tend to use a lot in my practice because most patients are already on once weekly GLP-1 receptor agonists, and sort of doing a combination, it's a bit of a regression in the dose of GLP-1 that they are already on. And it doesn't necessarily allow, if I need to go to a higher dose of insulin, I would need to break that pen combination again to the individual components. So it's an option, and it's great to have options in our toolbox because we need to individualize it. But in my clinical practice, and I think looking at a lot of data in Canada, these combinations are not commonly used. We tend to still use GLP-1 receptor agonists separately to maximize the weight loss and the A1C control and the insulin separately.
Yeah, I fully agree with you. And since we are with both component now talking weekly, it was a dramatic thing going from twice daily preprandially with GLP-1 to once weekly. And also we have to remind ourselves that in the vast majority of the CVOTs, the cardiovascular outcome trials, then higher amount of GLP-1 is actually used. So we want the patients to get as much benefit from the GLP-1 component as possible. But it's an interesting tool to have in the toolbox. It's for indeed some patients. It's not for all patients. In many countries, we will probably have to start once daily insulin first, but then if we're challenged by compliance or hypoglycemia or special situation with some patients, it's really interesting to have the once weekly tool in our toolbox.
I look at insulin weekly as an excellent choice for majority of patients living with diabetes. Probably not those who are planning or a pregnancy or pregnant, but for the majority of other people living with diabetes, it actually is a fantastic choice. Monitoring, I would say, is key to any insulin. So this is really where I would introduce the talk around CGM and sensor monitoring.
Yeah, and that actually bridges perfectly well to discussion number 3, which you're also able to actually go through with this program. Thank you very much, Jen, and thank you to everyone listening to this program of today.
Thank you.
Welcome to everyone out there. We will, in this part, discuss the implementation of continuous glucose monitoring in type 2 diabetes, why it should be considered, and how to consider it. My name is Tina Vilsbøll. I'm a professor at Steno Diabetes Center in Copenhagen. I'm an endocrinologist. And in this part, I'm joined by 3 really excellent and bright people. First one is Dr. Jen Zarifa. She's a primary care physician from Toronto, Canada. Then I am also honored to have Lori Berard on board. She's a nurse specialist with a lot of experience in CGM. And then finally, but definitely not least, when we are talking about insulin in type 2 diabetes, Ostap Soroka. He's a patient advocate, and it's really wonderful to have all 3 of you as part of this program today. Welcome.
Hello, Tina.
The whole idea about this part is to focus on whether CGM actually has a place in the treatment of type 2 diabetes. I myself, I'm a type 2 diabetologist, and for quite a long time, I've not been interested in CGM. It was too expensive, it was limited data, it was mainly, if at all, in type 1 diabetes. But I must realize that I'm seeing more and more evidence piling up. I have now learned time in range. It's now actually also in the treatment recommendation from the ADA and the ESD guidelines.
I think for the practice of diabetes, I feel CGM has sort of revolutionized how we look at the sugars, and there's a lot of benefits. The first one is nobody wants to finger poke. Nobody wants to finger poke at nighttime, and so having the ability to look at their sugar 24/7 without the finger poke is a huge benefit, particularly in people who are at risk of hypoglycemia, nighttime hypoglycemia, or they're unaware of their hypoglycemia. The ability to have alarms through these devices that would alert the person that their sugar is dropping is a huge benefit that we did not have access to before. And unlike the A1C, which actually is a great marker and we use it all the time, but it can be affected by a number of medical conditions and may not be accurate. Having data through CGM, there's a wealth of information. We get the time in ranges, which is a less abstract concept to people. So when you say, how much time are you spending in your range? That's something to completely understand. It's colorful. Green means good, red means bad. So looking at time below range, which is the hypoglycemia, time in range, and time above range. There's also evidence that it actually improves glycemic control overall, decreases time in hypoglycemia, and it increases patients' autonomy. It empowers them to make changes for themselves, which is a huge, huge benefit. Now, some limitations are access, obviously, to these devices, learning curve for both actually physicians as well as patients, and sometimes maybe it's too much data, and so we have to navigate that.
Yeah, I think I'll Lori, let's have you on board here. Can you just briefly tell us, what do you actually say to patients with type 2 diabetes about these TAR and TIR and TBR? Can you just very briefly explain us how you use it in the everyday clinical life?
Thank you. So I actually believe that there's a place for CGM across the continuum of type 2 diabetes. Everybody could benefit. But when we talk specifically about individuals who are on insulin or starting insulin, I think less is more. And using continuous glucose monitoring, and as Jen talked about, the ability to look at colors can really keep things very simple at a time that's very complex for them, adjusting insulins, starting insulins, remembering all of those sorts of things. So I don't take people through all of the features that continuous glucose monitoring can provide them. I talk to them specifically about, let's look at where you're at, how much time are you spending in the range that we want you to be in, 3.9 to 10. And most importantly, we do not want you spending time below range. So it's really easy for them to see at a glance that they're doing really well in terms of using their insulin. They can make food choices really, when you look at the little graph that tells them about the time that they're in range, they can see immediately the result of a food choice. And if they're at all concerned about the risk of hypoglycemia, you can really use these systems to sort of say, hey, you know what, let's take a look. You had no time below range. Your alarms are set. So you can use this as a comfort zone for them to be able to successfully move forward in their insulin journey. And again, like I said earlier, I believe that there's a place for it across the continuum of type 2 diabetes. It's just, we've always thought about it for individuals with type 1 diabetes.
Yeah. Thank you very much, Laurie. I'd love to bring Ostap on board here. Ostap, I know you are on what we call modern glucose-lowering drugs. You're on metformin, you're on SGLT2 inhibitor, you're on a GLP-1 receptor agonist, but you're also on insulin. Will you share your thoughts about that with us, please?
Sure, I love it. I love it. Sometimes there are some frustrations, but overall it's great. I've always said and read that more data is better data. All other things being equal, the more information you have, the better. That's certainly with me. And I now have, not just academically in other parts of my life, but now experiential, embodied understanding of that. And it's great. And the colors are great, but I really like getting into those numbers and seeing what's going on and monitoring it. I saw a change in how I did things and how my daily life was.
That's fantastic, and especially the virtual component. And with this, you can really have a dialogue. It's not only HbA1c as it used to be. One thing, I'll just come back to you, Jen, because one of the things that we as doctors, we're worried about some things. Individuals with diabetes are worried about different things. How do you use the shared decision making in your clinic every day?
Their goals are different. So it's really about having a discussion about what matters to them. And then I see my role as providing the education. This is what we have on the menu, and then we can pick and choose. And then, like Laurie said, is really starting slow and then building up on the knowledge. And then using resources. So we can't do it all by ourselves. I think there's a huge role for allied healthcare professionals.
Yeah, Laurie, what's your practical tips for doctors and patients in respect to CGM to take away from this?
I think it's really important that, it does not need to be something that people wear all the time. Intermittent use of it can be very helpful as well when we're thinking about access. But I also think that we have to be careful about things like data overload. And, Ostap talked about his journey and how he really likes using this information now, but it didn't happen overnight. So we have to be careful that we don't overload people with too much. I really think that we can use this to help people achieve their goals in the short term and in the long term, but we need to individualize how we utilize continuous glucose monitoring. And I think probably one of the most important things that I think about when we are talking about using this is that sometimes the individual that's wearing the device may not be capable of actually making a lot of their own decisions. But we as clinicians, if we can encourage the utilization of these systems, we can get a lot of information to help us make safer decisions with them. So sometimes they're monitoring for us. They're not necessarily always using it for themselves. And that's okay too. We'd love everybody to become empowered like Ostap is, but sometimes it's just about being able to get safer information so that we can make better decisions and help guide them along their journey.
And one of the things I try to educate my patients to is that you are controlling the diabetes. The diabetes is not controlling you, because I think that's important. You talked about, oh, it's nice to have all these measurements, but let me give the final word to you, Ostap.
I think it's great, and it does empower people who and as they are. Everyone is different, and everyone experience there are great similarities across the board because we can study it and have statistics, but every person, every body is slightly different, and you only get a few minutes of time at your clinician's office or with a nurse, and then you're on your own. So this is something that you can monitor, but also your medical providers can also monitor, and any information is good. So the fact that I like numbers is one thing. Other people use the colors or the alarms, and it fits them, because diabetes a lot of the time is silent. You don't know what's going on. You can be diabetic for years and not know, or you're told about all these horrible complications that might come decades later, and you're kind of frustrated in not knowing. And so in many different ways, it's empowering, and people could have the things they use with these monitors different from other people. And so it's flexible, it's helpful, and I think it's great.
Thank you so much, Ostap, for really enlightening us how it is to be actually, as you said, alone with your diabetes for a lot of time, or the majority of time. You're with your doctor or your nurse like 15, 30 minutes every second or third month or so. So that's really important, I think, for all of us to keep in mind.
I think my key takeaway is that diabetes has really evolved since I started in practice, that the medications that we have access to are amazing, and that utilizing continuous glucose monitoring really is the game changer, especially for individuals now living with type 2 diabetes. One of the key messages that I like to share with individuals living with diabetes is that they are in control, that they can become empowered through education, that we are really there to guide them along their journey, and that utilizing these tools can really help them to achieve their goals.
I just loved all your perspectives in this session, and thank you everyone out there for listening to our session today.